Hello everyone, welcome to our lecture on sickle cell anemia, which is one of our exemplars within our comfort concept. So we're going to go over how this hereditary condition impacts patients' comfort. We're going to focus on its pathophysiology, clinical manifestations, and nursing intervention. So by the end of this lecture, you should have a deeper understanding of how to care for patients who are experiencing the challenges of sickle cell anemia and help improve their quality of life. So let's get started. So sickle cell anemia is an autosomal recessive disorder that's caused by the inheritance of two copies of the sickle hemoglobin gene, or HbS. So this mutation leads to the production of defective hemoglobin, which alters the shape and functionality of red blood cells whenever they're exposed to low oxygen levels. So instead of the normal round and flexible structure, these cells become rigid and sickle-shaped, causing them to clump together and obstruct blood flow. So this obstruction, known as a vaso-occlusive crisis or sickle cell crisis, leads to a decreased blood perfusion and oxygen delivery to tissues, causing pain, tissue ischemia, and damage. And we'll talk about this a little bit more in depth on the next slide. So our sickled cells in these patients with sickle cell anemia are also very fragile. They only have a lifespan of about 10 to 20 days, which compared to the normal 120 days of a normal red blood cell, you can see how these patients end up with a chronic anemia and other complications. So sickle cell anemia primarily affects African Americans, with approximately 1 in 500 individuals having the disease and 1 in 13 carrying the one sickle cell gene allele. So this condition leads to very significant challenges, things like chronic pain, organ damage, and increased risk of infection and early death. And while there's currently not a cure, there are some ongoing advancements in treatment to help improve the quality of life and outcomes for patients who are living with this disease. All right, so looking a little more in depth to our vaso-occlusive crises or sickle cell crisis. So these are a hallmark of sickle cell anemia. And these events occur whenever sickled red blood cells adhere to vessel walls, which obstructs blood flow to tissues and organs. So this blockage causes ischemia, which we know is a reduced oxygen supply to tissues and to organs. And in severe cases, we can actually have infarction of the affected tissues. Patients have symptoms like intense pain, swelling, and fever during these crises. There are some conditions that can cause or trigger sickle cell crises. Hypoxia, which obviously we know that these sickled cells become sickled because of low oxygen levels. So hypoxia is a major trigger or cause. But we also have cold, which causes vasoconstriction, dehydration, venous stasis, pregnancy, infection, strenuous exercise, nicotine use, anesthesia, emotional distress, and trauma, all of which can, again, trigger or worsen a sickling episode. There is a specific type of crisis, which is known as a sequestration crisis, which occurs whenever sickled cells pool in organs, such as in the spleen in children, or in the liver and in the lungs in adults. So this pooling causes infarcts and scar tissue formation, which can ultimately lead to organ failure. So the good news is that these sickle cell crises can often be reversed if the patient receives adequate oxygen before the cells become too rigid. However, repeated crises can lead to long-term damage, including things like chronic organ dysfunction and reduced life expectancy. So these crises are typically intermittent. Again, like I talked about earlier, they can be triggered by a whole range of different factors. So as nurses, it's very important for us to educate patients to avoid these triggers as a big component of their care. We also, as nurses, need to be able to recognize these crises early to be able to act promptly so that we can alleviate any of the symptoms and so that we can restore that oxygenation. So understanding the triggers and the complications of a vaso-occlusive crisis helps us to provide comprehensive and patient-centered care. So the picture on this slide gives a really good visual summary of the pathophysiology of sickle cell disease and its impact on the body. So again, the disorder begins with that genetic mutation as represented by the chromosome on the left. So this mutation then leads to the production of abnormal hemoglobin, which causes our red blood cells to take on that sickle shape. So these sickled cells then obstruct small blood vessels, which disrupts the flow of oxygen to tissues. As you can see here in the picture, this blockage can lead to severe pain, tissue ischemia, and damage. And over time, this tissue damage can result in long-term complications and organ dysfunction. So a critical aspect of care for patients with sickle cell disease is continuous monitoring for complications such as acute pain crises, infection, and organ damage. All right, moving into our nursing assessment for sickle cell disease. So assessment is very important to be able to manage sickle cell disease because it allows us to be able to identify cues that may indicate a crisis or a complication. So we always start with our assessment by gathering the patient's history, and we want to begin by asking about any previous crises, specifically asking about what triggered them, the severity, and how the crisis was managed. This provides really important context for understanding the patient's condition and their typical response to crises. Next, we're going to assess any recent contact with ill individuals because infection is a common trigger for sickle cell crises. We're also going to explore the patient's activities over the past 24 hours. So this includes reviewing their food and their fluid intake, any exposure to temperature extremes, the medications that they've taken, exercise, recent trauma, stress, or even any recent travel, such as like on airplane flights. Also, we want to consider alcohol, tobacco, or recreational drug use because all of these can exacerbate symptoms as well. We're going to ask the patient about if they've had any changes in sleep and rest, and about their rest patterns and their ability to perform any activities like climbing stairs or engaging in tasks that might cause shortness of breath. Finally, we're going to also ask about their perceived energy level using that 0 to 10, where a 0 represents fully energized and 10 indicating complete exhaustion. So essentially the scale is how exhausted are you. So this helps to quantify their fatigue and their overall well-being. So by carefully recognizing these cues from their history, we can help identify any potential triggers so that we can intervene early and provide appropriate care. So whenever we're assessing patients with sickle cell disease, our physical exam focuses on recognizing cues that can reflect reduced perfusion and tissue damage. So pain is the most common symptom during a crisis, and it varies depending on the site of reduced blood flow. So the rest of our symptoms we're going to break down by system. So within our cardiovascular system, we want to look for any signs of high output heart failure. So we may see things like heart murmurs, tachycardia, and hypotension. The peripheral pulses may also be weak or absent in areas where there is reduced blood flow, and the extremities might feel cool to the touch. Cap refill is usually going to be delayed. All of these findings indicate a compromised perfusion. As far as the respiratory system goes, these patients are at risk for pulmonary hypertension and acute chest syndrome, which is a life-threatening complication that's usually associated with respiratory infection. So symptoms can mimic pneumonia, including a cough, shortness of breath, and abnormal lung sounds. Acute chest syndrome requires immediate intervention to prevent any respiratory failure and multiple organ dysfunction. As far as our skin changes go, we want to look for pallor or cyanosis and jaundice, all of which can be caused by anemia and red blood cell destruction. So in our darker skinned patients, jaundice can be assessed by inspecting the sclera and the roof of their mouth. Chronic poor perfusion can also lead to lower extremity ulcers, which may also become necrotic or infected. Looking at the abdomen, so the spleen and the liver are very commonly affected by repeated hypoxia and ischemia. As far as the spleen, again, is usually mostly seen affected in children, where the liver and the lungs are more seen in adults. So during a crisis, abdominal pain is often diffuse and it's very steady. Sometimes it radiates to the back and to the legs. So we want to palpate the abdomen for any organ enlargement or any sort of nodular texture. As far as the kidneys and the urinary system go, so chronic kidney disease is a very common complication due to anoxia. Patients may show proteinuria or protein in their urine, or they may have an inability to concentrate their urine. So in severe cases, kidney failure can result in little or no urine output. Musculoskeletally, so blood vessel occlusion often affects the joints, which leads to swelling, pain, and decreased range of motion. Over time, hypoxic damage can cause joint necrosis, so we want to be sure to document any changes in movement or appearance of the arms and the legs. With the central nervous system, or CNS, repeated episodes of hypoxia can cause cerebral infarcts, which causes stroke-like symptoms or even seizures. So we want to assess for a pronator drift, bilateral hand strength, and coordination and gait. Patients can also present with a low-grade fever during a crisis as well. We can also see a priapism, which can happen. So during a normal erection for our male patients, blood flows into the penis and it becomes rigid. After ejaculation, the hormones are then released, which allows the blood to drain. However, in a patient with sickle cell, if the sickled red blood cells cause a blockage, then the blood can't drain and then the penis stays erect, which is known as a priapism. So by performing a very thorough physical assessment, nurses can help recognize critical cues that can help guide timely and effective interventions. Early detection and management is very important for preventing further complications, like a lot of the ones that we talked about here. All right, so we're going to look a little bit deeper into the systemic impact of sickle cell disease. And this picture does a good job of showing the widespread systemic effects of sickle cell, again, caused by those sickled shaped red blood cells. So as far as the skin and extremities, poor perfusion and oxygenation can cause pallor, cyanosis, and it can also lead to ulcers, especially in the lower extremities. Swelling and pain in the hands and the feet are also very common in children. As far as the bones go, repeated vasoocclusion in the bone marrow can cause chronic hypoxia and ischemia, which causes bone pain, osteoporosis, and an increased risk of fractures. The spleen is often one of the first organs to be affected. We see splenic infarcts, and eventually we can see functional asplenia. So this complication really puts patients at a higher risk for infections, especially in the pediatric population with sickle cell. As far as the lungs go, we have pulmonary complications, things like pulmonary hypertension or high blood pressure. They can have pneumonia and that acute chest syndrome that I talked about in the previous slide, all of which are major causes of hospitalization and mortality. With the kidneys, so we can have hypoxia and poor perfusion, which lead to that chronic kidney disease, proteinuria, and again, in severe cases, kidney failure. With the central nervous system, so again, we can start to see, because of repeated episodes of hypoxia, we can see things like strokes, or just cerebral infarcts, which leads to long-term neurological complications. And then genitourinary, again, that priapism, which is a very common complication in our male patients, and again, it's due to just vascular engorgement. So as you can see, sickle cell disease affects multiple organ systems. So really emphasizing the importance of holistic and preventative care is a big part of our nursing care. Managing these complications early is key so that we can improve quality of life and the outcomes for patients with this condition. So accurate diagnosis and ongoing monitoring of sickle cell disease rely on both laboratory and imaging assessment. So we're going to first look at our laboratory findings. So a diagnosis of sickle cell disease is confirmed by determining the percentage of hemoglobin S, or HbS, through electrophoresis. So in patients with this disease, HbS levels typically range from 80 to 100%. Which compared to less than 40% in those who just have the sickle cell trait. So the presence of red blood cells with permanent sickling is another key diagnostic factor, reaching up to 90% in patients with sickle cell disease. Other lab tests highlight complications. So patients with sickle cell disease often will have a low hematocrit or hemoglobin level. So the hematocrit levels will typically be between 20 and 30%, just simply due to that shortened lifespan of the red blood cells. So during a crisis or periods of stress, the hematocrit levels can drop even further. The reticulocyte counts are also going to be elevated, which shows the body's attempt to compensate for that chronic anemia. High bilirubin levels also happen just due to the destruction of red blood cells. And white blood cell counts are also may be found to be elevated just simply due to chronic inflammation that's caused by that hypoxia and ischemia to tissues. As far as our imaging assessment goes, so imaging studies really help us identify the structural changes that are caused by chronic hypoxia and ischemia. So our x-rays may reveal bone changes, including things like joint necrosis and destruction, as well as the characteristic crew cut appearance in the skull due to bone marrow hyperactivity. So we start to see enlarged facial and skull bones. We can also have advanced imaging. Things like CT scans, PET scans, and MRIs are very useful for detecting soft tissue and organ changes that are linked to poor perfusion and chronic inflammation. So together, lab and imaging assessments can help provide critical information for diagnosing sickle cell disease. We can also use these assessments to monitor its progression and identify any complications early. All right, so once we've gathered and assessed the relevant data, now we need to analyze the cues and prioritize our hypotheses to be able to determine the most critical problems that the patient with sickle cell disease is facing. So in this population, there are two key priority problems. The first is pain, and pain is a direct result of poor tissue perfusion and joint destruction that's caused by that lack of oxygen delivery to the tissues. So this is one of the most frequent and debilitating symptoms that's experienced by patients during a sickle cell crisis. Our second problem is the potential for infection, sepsis, and MODS, which is known as multiple organ dysfunction syndrome. So due to compromised immune function, reduced splenic activity, and chronic inflammation, patients with sickle cell disease are at a high risk for infections that can rapidly progress to sepsis. So without timely intervention, sepsis can lead to multiple organ dysfunction syndrome or MODS, and then ultimately can lead to death. So these priority problems, so pain and this potential for infection, sepsis, and MODS, really show how important it is to have timely and effective interventions to manage these problems. So by focusing on these hypotheses, we can address the most immediate threats to the patient's well-being while working to improve their overall quality of life. So as we discussed on the previous slide, managing pain is one of the most critical aspects of care for patients with sickle cell disease, especially during a crisis. So pain results from tissue injury that's caused by poor perfusion and inadequate gas exchange, and it can be severe enough to require hospitalization. So the goal of pain management is to reduce pain to an acceptable level to the patient, allowing them to participate in self-care and daily activities. So management strategies are going to be individualized based on the patient's past pain history, their previous drug use, their current assessment, and disease complications. So we're going to go over some of the key interventions here. So first we have drug therapy. So morphine and hydromorphone are the mainstays of treatment during an acute pain crisis, and they're typically given intravenously for at least 48 hours on a routine schedule or through a PCA pump. So once the pain is controlled, dosing can transition to the oral route. PRN schedules are typically going to be avoided because they usually fail to provide adequate relief. Another medication is hydroxyurea, and this medication reduces the frequency of sickling and pain episodes, and that's because it stimulates the production of fetal hemoglobin. However, this medication carries risks such as bone marrow suppression and an increased risk for leukemia. So regular monitoring of this drug is very important. Indari is a glutamine-based therapy. It helps to reduce oxidative stress in red blood cells, which can decrease sickling, and it can also increase the cell's lifespan. Lastly, we have crizanlizumab, which is a monoclonal antibody that reduces vaso-occlusive crises by preventing cell adhesion. So it's administered typically as a once a month infusion. Another therapy that we can utilize to manage pain is hydration. So maintaining hydration through oral fluids or IV hypotonic fluids is very important for reducing the duration and the severity of pain episodes. It also helps restore perfusion and tissue oxygenation. And third, we have integrative therapies. So non-pharmacological methods such as keeping the room warm, positioning painful areas for support, using relaxation techniques, distraction, aromatherapy, therapeutic touch, and warm soaks or compresses can all enhance comfort and reduce pain perception. So it's important to acknowledge that some patients may have had a negative past experience with healthcare providers who have underestimated their pain. So as nurses, we need to ensure that our approach is compassionate, non-judgmental, and based on the patient's reported experience of their pain. And effective pain management improves outcomes and quality of life for patients who have sickle cell disease. All right, so whenever we're managing a sickle cell or vaso-occlusive crisis in a patient with sickle cell disease, the primary focus is on relieving pain, improving oxygenation, and promoting circulation so that we can minimize any complications. So let's break down some of these key interventions. So first is administer oxygen. This helps to enhance oxygen delivery to tissues and reduce hypoxia, which contributes, again, to that sickling of the red blood cells. So if we can give oxygen, hopefully we can reduce the sickling. Second, we can administer prescribed pain medications. Again, IV opioids. We are typically used to manage the severe pain that's associated with the crisis. Pain medication needs to be proactive and based on the patient's reported experience. Third, we need to hydrate the patient with IV. Typically, we're going to use normal saline. We can also use hypotonic solutions to restore fluid balance and encourage perfusion. We also want to provide oral hydration with caffeine-free beverages to support this hydration effort. Next, we can remove any constrictive clothing because anything that's constrictive can impede blood flow. We also need to encourage the patient to keep their extremities extended so that we can promote venous return. So avoid flexing the knee position of the bed because this can restrict blood flow. We also want to elevate the head of the bed to no more than 30 degrees to support oxygenation without compromising venous return. We need to maintain the room at a temperature at or above about 72 degrees to prevent any vasoconstriction that's caused by cold exposure. We want to avoid using standard or automatic external arm cuffs for blood pressure measurements because these can also compromise circulation. And we need to check circulation in the extremities hourly, including assessing pulse oximetry of fingers and toes, looking at peripheral pulses and capillary refill times. This just helps to ensure that perfusion is maintained. So by implementing all of these measures, we can reduce the duration and the severity of the crisis while preventing complications like tissue ischemia and organ damage. All right, so moving on to our second identified problem here. So remember, these patients are at higher risk for developing sepsis, MODS, and death. So let's talk about the interventions that we can use to help prevent these things from happening. And the first is just through prevention and early detection. So hand washing, the use of masks, and strict aseptic technique are going to be very important to help protect patients who are in a vaso-occlusive crisis or a sickle cell crisis from infection. So frequent assessments for infection are going to be things like monitoring for a fever, inspecting the mouth for any lesions, listening to those lungs for any crackles or wheezes, and checking their urine for any odor or for any cloudiness. And we're also going to monitor their vital signs at least every 4 hours. Drug therapy, so we can utilize prophylactic antibiotics such as twice-a-day oral penicillin. These can help reduce the incidence of infections like pneumonia. Also, vaccinations, like the pneumonia vaccine or the annual flu vaccine, are also going to be very important as prophylactic measures. As far as, so we want to prevent a vaso-occlusive crisis, and we want to be sure that we can minimize where they can lead to things like an acute chest syndrome, which is a major cause of death in patients with sickle cell disease. So by preventing heart and lung damage, by promoting perfusion and oxygenation, we can prevent things like this from happening. And this is an absolute priority. Adequate hydration with oral or IV fluids can help decrease the risk of cell sickling, and it can also promote perfusion. Patients in a crisis require an intake of at least 200 milliliters per hour of fluids. Oxygen therapy. So nebulized oxygen prevents dehydration during oxygen administration. So we want to monitor oxygen saturation very closely, and if it's low, then we may need to evaluate with an ABG or a chest x-ray. Blood transfusion. So red blood cell transfusions can increase hemoglobin A levels, and it can actually dilute the hemoglobin S. So this can reduce the risk of sickling. However, with blood transfusions, they need to be used cautiously to prevent complications such as like an iron overload. Lastly, we have a hematopoietic stem cell transplantation, or HSCT. These have a potential cure for sickle cell by correcting that abnormal hemoglobin, but it's very costly and it carries a lot of risks. So currently, this is not a widely approved therapy for adults, but it's a promising option that's under investigation. All right, so let's talk about care coordination and transition management. Mostly, we're going to be talking about patient and family education, so how they can prevent a sickle cell or vaso-occlusive crisis. And first things first, hydration. So we want to encourage the patient to drink at least 3 to 4 liters of fluids daily to prevent dehydration, which is a major trigger for sickling. Caffeinated and alcoholic beverages need to be avoided because they can contribute to dehydration. Lifestyle modification. So avoid smoking or using tobacco or nicotine products because these can impair circulation and they can exacerbate the hypoxia. We also want to teach these patients to stay away from hot and cold temperature extremes, teaching them to wear socks and gloves whenever they're going outside in cold weather so that we can prevent vasoconstriction. Our preventative health measures, so we need to teach them to contact their healthcare provider at the first sign of illness or infection so that we can prevent complications, and teach them about annual vaccines, including the flu shot and the pneumonia vaccine, which is every few years, how essential these are. Travel considerations. So we want to teach patients to avoid unpressurized airplane cabins and high altitude destinations, places like Denver, Colorado, or Flagstaff, Arizona, because these high altitude areas can reduce oxygen levels and can actually trigger a sickling episode. Communications with providers. So we need to make sure that all healthcare providers, including radiologists and anesthesiologists, are aware of the patient's diagnosis so that we can avoid complications during any procedures. Also, genetic counseling. We may need to recommend this to patients who are considering starting a family because this can help them understand the genetic transmission of sickle cell disease and be able to explore family planning options. Also, exercise. So we want to teach patients to avoid strenuous physical activity, which can lead to hypoxia. So instead, we want them to engage in like a mild, low impact exercise about 3 times a week whenever they're not in a crisis. So by teaching these different strategies, we can empower patients and their families to actively participate in managing their sickle cell disease, which reduces the likelihood of a crisis. It improves their overall quality of life as well. So also, Referring families to support groups or resources such as like the Sickle Cell Foundation can also be very valuable as far as emotional and social support go. All right, so for our last slide here is just a picture that summarizes the key aspects of sickle cell disease, starting with its genetic cause. So the disorder arises from that mutation in the gene that codes for hemoglobin, which causes red blood cells to take on that sickle shape whenever they're in low oxygen situations. So under the sickle cell umbrella, the most severe condition is sickle cell anemia. So this shape change in red blood cells is more than just structural, so it causes significant complications. Again, the sickled cell becomes very rigid and sticky, which leads to poor blood flow and blockages in small vessels, which, as we know, is a vaso-occlusion or sickle cell crisis. Causes a lot of pain and even ischemia, and it can also lead to organ death. So there are several triggers for sickling episodes, things like stress, extreme temperatures, dehydration, and infections. All of these factors can exacerbate the condition by increasing that oxygen demand and reducing the oxygen supply to tissues. So during a sickle cell crisis, patients can experience a lot of extreme pain, which requires immediate and appropriate intervention. So it's important for us as nurses to recognize and address these episodes quickly so that we can prevent further complications. Finally, long-term complications of sickle cell disease include organ damage due to repeated ischemic episodes. The spleen is particularly vulnerable, which makes patients more susceptible to infections, which is a leading cause of morbidity in these individuals.